My name is Gwen Unger. I'm with Healthcare Durango. And one of the things that we really concentrate on is universal health care. We think that everybody should be able to get the health care that they need, regardless of whoever they are. So you can email us at healthcaredurango@gmail.com, and we'd be more than happy to answer any questions you might have. We also now have a website, which is healthcaredurango.com. Just wanted to recognize some of the Healthcare Durango key members. These are people who have been working really hard. I'm not doing all this by myself, that's for sure. So we've got a group of people that are really dedicated to this. One thing we're going to do this time that's a little different, we're going to do audience participation. Okay? So don't let that scare you. What's going to happen is I'm going to put up a slide and it's going to have a statement. It's going to say something on it. And then I'd like each of you to raise your hand and say you think that's true, or it's a myth, which means it's false, or it's a misconception, which means depending on how you interpret it, and it might be partially true, might not. So here's a sample slide, and this statement says healthcare should be a human right. So as we do each one of these slides, I'll say, okay, everybody that wants to vote true, put your hand up. Everybody who wants to vote false, put your hand up. And if you think it's just a misconception, put your hand up, okay? Now, in this particular case, this is sort of a trick question because there's not really a fact involved with that. That's purely an opinion, right? I mean, some people believe that healthcare should be a human right. Other people believe it should just be a consumer product and whoever can afford to buy it should get it. So all the rest of these will be something that's either true, a myth, or a misconception. So the name of the program today is Medicare for All, Myths and Misconceptions. So try to say that 5 times in a row. Myths and misconceptions. So let's go to the first statement, and it says the United States is the only developed country that does not have universal health care. Trues? False? Misconceptions. And the answer is it's true. We are the only developed country in the world that does not have universal health care. That doesn't mean there aren't some undeveloped countries that don't have universal health care. There's a lot of those. But among the developed countries, we're the only one that doesn't have it. So next statement. In 2017, there were still 28.5 million people uninsured in the U.S. True? Myth? Misconception? That one is in fact true. In addition to that, tens of millions more were underinsured. So what do we mean by underinsured? That means that people have insurance, but they can't afford to use it. So many people today have deductibles that are $5,000, $6,000, $10,000. That means that person has to pay that much before the insurance kicks in. And there's an awful lot of people that can't afford to do that. So that's what we mean by underinsured. They technically have an insurance policy, but the deductibles have gotten so high that they can't afford to use the insurance. Next one, universal health care defines a specific way of providing health care to everyone. So if I say universal health care, that means a specific way of doing it. Trues? Myth? Misconception? So that's actually a myth. Universal health care is not a single system. It can be any type of system as long as it covers everybody. So that's the idea behind universal. Everyone is covered. So that's a good thing to remember. Statement, in 2018, we spent $3.65 trillion on healthcare. And I wrote it out there so you can see how many zeros that means. True? Myth? Misconception? That one's true. If you take that $3.65 trillion, divide it by the population, it comes to about $10,500 per person that we spent on health care last year, which then means $42,000 for every family of 4. That doesn't mean every family of 4 paid that, but just on average, we spent $42,000 in this country on health care per family of 4. Okay, in 2018, we spent almost as much on health care as on defense. True? So that's definitely a myth. We spent over 5 times as much on health care as we did on defense last year. Okay, you can see the 3 point, you probably can't see the numbers, but $3,650 billion on healthcare and only $700 billion on defense. So we're spending a whole lot of money on healthcare. Next one, we spend roughly twice as much per person as other developed countries. True? Myth? Misconception? It's true. Okay, you can see we spent $10,209 in the United States, Germany at $5,700, France $4,900, Canada $4,800, United Kingdom $4,200. So we're spending roughly twice as much per person as these other developed countries. It's going to be one of those days. Let's see if this does anything.
Costs, as I say, if we look through medical equipment, prescription drugs, physicians' payments, dentists, we pay twice as much as everyone else in the world. Now, will we get down to other levels? That's an open question. But there's no obvious reason we should be paying twice as much for our drugs, for our medical equipment as people in France and Germany. We don't pay our auto workers twice as much. We don't pay twice as much for cars. It's not clear why we should pay twice as much for health care.
And he's saying the same thing that we just said. Next one, healthcare costs in the U.S. are rising slightly faster than the overall inflation rate. True? Myth? Misconception? I'm going to call it a myth. If you look at this chart, this shows the medical inflation rate. So everybody knows that inflation is where something costs more than it did last year, right? That's the definition of inflation. It costs more for the same thing. So the medical inflation rate, and this information came from PricewaterhouseCoopers, in 2007, the first line you see there, the medical inflation rate was 12%. That means prices went up 12% in 2007 for medical. The overall inflation rate was 2.8%. So I would say that's not slightly higher, I'd say that's lots higher. You can see in 2009, the overall inflation rate actually went down 0.4%. That was the beginning of the Great Recession, right? And yet medical prices still went up 9.3%. And you can see here in 2014, 15, and 16, the medical inflation rate was over 6%. So I want you to remember that 6% medical inflation rate, because we'll come back to that a little bit. And if you compound these numbers, that's the very bottom thing, medical inflation medical prices went up 125% over that 10-year period, whereas the overall inflation rate was 20%. So again, I would say it's going up a lot more than just a little bit over the inflation rate. So the economists generally try to come up with sort of an overall inflation rate for the whole country. If you took everything that was sold in the country, compared its price this year to last year, that's how much it went up. Okay, statement, the additional healthcare spending in the U.S. is because we use more healthcare. True? Myth? Misconception? Oh, you're doing great. So that's a myth. This comes from the New York Times. Studies point to a simple reason: the prices, not to the amount of care. And lowering prices would upset a lot of people in the health industry. So again, we don't use more care per person, we just pay a lot more for it. Next statement, medical care debt is the #1 reason for personal bankruptcy. True? Myth? Misconception? So I actually was just reading an article yesterday, I think it was, and Bernie Sanders has been saying 500,000 medical bankruptcies, and the person was claiming, well, they're not all because of medical. But you can imagine if you start getting in trouble paying your medical bills and then you've got other bills to pay, it's going to be a combination of the different things. But medical bills are a major role in about 500,000 medical bankruptcies each year, which means somebody loses everything they have because they got sick or they got hurt. Next statement, by spending more, we get better healthcare outcomes. That would seem reasonable, right? We're spending a lot more, we should get better healthcare outcomes. I may be tipping this one. Is that true? Anybody true? Myth? Misconception? So I'm going to say it's a misconception, and I'll tell you why in a minute. But this is the latest look at the U.S. healthcare system, and this is done by the Commonwealth Fund, had us last among the 11 countries that they track. And they've been tracking them for a decade. And we've been last every year. In healthcare outcomes, that's how well are things actually coming out. And that was 2014 data. Here's the 2017 data, and you can see we're still dead last. Now, I had somebody send me a response to a Facebook post that I sent out, and they said, why did, and I can't remember if it was Mick Jagger or one of the Rolling Stones, why did he come to the US to get heart surgery? And my answer is, because he's rich. If you are rich, you can definitely get the best healthcare in the world here in the US. Okay, you can go to the Mayo Clinic, you can go to MD Anderson Cancer Center in Houston, no question. If you can afford to do it, you can get the best healthcare. But the problem is we have a whole bunch of people who can't get any healthcare, certainly can't go to the Mayo Clinic. And so when you average it all out, that's what the Commonwealth Fund is doing and saying we're last. So not only do we spend twice as much money, but we don't get as good a healthcare outcomes on average. Statement, healthcare administrative costs are relatively low. True? False? Misconception? That's definitely a myth. I'm going to point out why here. I'm going to blow up this chart so you can see it a little bit better. So you see this brown area down here at the bottom is pretty thin. That's the growth in physicians year by year from 1970 to 2009. Fairly low, steady growth, probably just because the population was increasing. The green part is the growth in administrators over that same time period. And so what really happened was back in about 1980, 85, 90, the providers started taking over making insurance claims. If any of you are old enough to remember back before that, you had to go to the doctor, you got a bill, you sent it off to the insurance company, and then they would send you some money maybe. Okay? But that wasn't working very well, so the providers, the doctors, the hospitals, and so on, started filing the insurance claims for people. Well, what does it take to manage all of filing those claims? It takes a lot of people. And so in this case, it takes a lot of administrators. There was, I went to a meeting Monday morning, I think it was, and somebody from Access Health was there. I believe he's the CEO of Access Health. And he said they have 104 different revenue streams. So that's places that they're getting money from. Most of those are insurance company plans. So they have to manage filing claims and getting payment from 104 different places. So you can see why it would take a tremendous amount of administration in order to do this. And I've had doctors tell me they spend 35% of their practice income on administration, mostly related to insurance. Okay, so there's three things I want you to remember as we go along here. Number one, our healthcare prices and therefore healthcare spending are much too high in the US. That's that $3.65 trillion. Okay, remember that. Our prices, our spending is much too high. The second one is the medical inflation rate is several times higher than the overall inflation rate. That was what we talked about a minute ago. Remember that the medical inflation is about 6% or a little higher. Okay, this is going to be important as we go along here. And the third thing is, and we haven't talked about this, but there's very little in our current system that can hold down prices and price increases. Anybody think of anything that would hold down medical prices? You'd sort of like to think competition might, but we could spend probably a half hour talking about how that really works. Okay, so just remember that. There's very little in our current system that can hold down prices and price increases. That doesn't sound good when you compare it with that 6% every year going up, right? Okay, next statement. Healthcare is now and traditionally has been a liberal issue. True? Myth? Misconception? Yeah, that one's a little fuzzy, right? So I say it's a misconception. Obviously, everybody needs health care at times, right? It's not just liberals that need health care. Conservatives, people in the middle, everybody needs health care from time to time. And a couple of interesting things here. The Canadian Medicare system, that's what they call their single-payer system, was created by Tommy Douglas, and he was a conservative prime minister of Saskatchewan province. So it started in Saskatchewan, and it spread across the country. And he was very conservative. They did a poll a year or two ago, and they asked Canadians, who's your Canadian hero of all time? Who do you think they picked? Tommy Douglas. which shows you how much they really appreciate the system that they have in Canada. And of course, the Massachusetts healthcare system was created by Governor Mitt Romney, who was a Republican. So I don't personally see any reason why this should be a liberal issue. I realize that some people are taking money from pharmaceutical corporations, insurance companies, for-profit hospitals, that kind of stuff, so they may have good reasons to think that we shouldn't do anything different than we're doing now. But in general, this shouldn't be a liberal issue, in my opinion. So next statement, most other developed countries have a single-payer healthcare system. True? Myth? Misconception? So it's a misconception. There's generally 3 different ways in which developed countries pay for healthcare. Number 1 is government-controlled healthcare. So if you go to the United Kingdom, to England, the government owns the hospitals and the clinics and the equipment, and they employ the doctors and the nurses and all the other people. So that truly is government-controlled, government-run healthcare. And you can see Italy, Spain, Hong Kong are other examples of that same thing. And then there's mandated and regulated private insurance. So that's what you see in Germany, Japan, Belgium, Switzerland, for example, where they regulate the insurance company pretty heavily. Most of them have to compete based on customer service, how well they do things. They all have to cover a basic set of things. So that's the second way. And the third way is single payer. And single payer simply means that one entity pays for everybody's health care, typically the government. So in a single payer system like Canada, Australia, Taiwan, or South Korea, you have private companies and private individuals who are providing health care. They're the providers, but then the government pays for all of it. Okay, so don't confuse single payer with universal health care. Single payer is one way to implement universal health care, but there are others that people are doing. Next one, Medicare for all means everyone goes onto the existing Medicare system. True? Myth? Misconception? Okay, I labeled it a misconception. So let's talk about what is the existing Medicare system. So it's a medical payment system supported primarily by payroll taxes, and when you reach age 65, Medicare pays for about 80% of incurred medical expenses after you pay your deductible. Now, in the case of Medicare, the deductible is only $185, not $5,000 or $6,000. And then you pay a premium every month, which is $135.50 per month for 2019, although it may be higher for some income earners. But that's not really what we're talking about when we talk about Medicare for all, based on the bills that have been introduced in the House and the Senate. So what we prefer to call this is National Improved Medicare for All, or I may abbreviate that to NEMA, just to not have to say that every time. So what is it? National, so it's a program of the United States federal government. That's what national means in this context. It's improved because it has more comprehensive benefits than our current Medicare. Medicare, it's an extension of the existing system. So we're not talking about putting everybody onto the existing system, we're talking about putting them onto something that's an extension of the existing system. And all means everyone's health care needs are covered. So we'll talk a little bit more about that here. There are currently 2 bills in Congress for Medicare for all. So the Medicare for All Act of 2019 was introduced in the House of Representatives by Pramila Jayapal. I put it was just introduced, but it's actually been, 3, 4, 5 months now. And of course, the Medicare for All Act was introduced by Bernie Sanders in the Senate in 2019. Originally in 2018, then he reintroduced it in 2019. And there's some differences between the 2 bills, but they're fairly similar. Probably the biggest difference is the Bernie bill goes in over a 4-year period. They start bringing people into the system. Not everybody comes in at once. It takes 4 years before everybody's covered. And the Jayapal bill just takes 2 years to cover everybody. So let's just compare NEMA against current Medicare. Current Medicare covers 65 and older. NEMA covers everyone. Current Medicare is supported mostly by payroll taxes. We don't know at this point exactly what sort of taxes would be used for Medicare for all, but we wouldn't be too surprised if it's pretty similar. Monthly premium, no monthly premium on NEMA. This is a little bit of a contentious issue. Some people think that everybody ought to pay at least a little bit. But then, of course, if you do that, you end up with somebody who can't afford even a little bit and doesn't get covered. NEMA would cover 100% of charges with no deductible instead of 80% after the deductible. Current Medicare is optional. Even when you turn 65, you don't have to sign up for it. NEMA would be required. Everybody would just go into it. Under current Medicare, not all providers participate. Medicare reimbursement rates are lower than private insurance reimbursement rates, so some providers say, we're not going to cover Medicare patients. Or they say, we're going to cover a few Medicare patients, but we don't want a whole bunch of them. Under NEMA, there wouldn't be any place else for providers to get paid, so they would almost all participate. And we talk about there might be some dermatology practice in Los Angeles where they do tummy tucks and that kind of stuff that's purely cosmetic, and you have to go pay them cash. Medicare wouldn't cover that. Under current Medicare, there's no dental, vision, or hearing aid benefits, so NEMA would have comprehensive benefits in that area. If you think about it, if somebody's got severe dental problems, if they can't hear well, if they can't see, they're really not very healthy. And under current Medicare, if you want drug coverage, you have to buy into Part D, which is limited. I can tell you it's limited because I'm on it. All sorts of issues with that, whereas under NEMA, you'd have comprehensive drug coverage. So we're going to do a little more voting here. Medicare for all would cost $32 trillion per year. True? Myth? Misconception? That's definitely a myth. The gross national product of the United States last year was only $20.5 trillion. There's no way in the world we could spend $32 trillion on Medicare, right? So that was a trick question. If you got that one wrong, it's all right. Okay, next statement. Medicare for all will cost $3.2 trillion a year, and we can't afford that. True? Myth? Misconception? Okay, I'm going to play another video. I hope the sound doesn't blast us out of here.
It's frightening. Estimates, as you mentioned, up to $32 trillion. Almost.
Just say to you, Medicare for all is expected to cost $32 trillion, over 10.
Now, we know that Medicare for all represents a $32 trillion expenditure to the federal budget.
Those were 3 United States Congress people in the House Rules Committee hearing some months ago who all said it's going to cost $32 trillion. Now, they are talking about over a decade. So that would be $3.2 trillion per year, right? So let's talk about that. I say that's really a misconception, okay? $32 trillion over 10 years. That's $3.2 trillion a year. We spent $3.65 trillion last year. We saved $450 billion the first year. Sounds pretty good, right? Believe me, that's not what those congressmen, they were complaining about how much it was going to cost, and yet if it was really $32 trillion over 10 years, we'd be saving a bunch of money. They're all wrong. What the study that came up with that number said was that government expenditures would increase by $32 trillion. So it'd be $32 trillion in addition to what we're already spending. That's what Dr. Blehaus said in that study. So I'm going to play another little clip here. This is Dr. Blehaus, Charles Blehaus, who did the study for the Mercatus Institute.
Total federal spending on Medicare for all over the first 10 years would be somewhere between $54.6 trillion and $60.7 trillion.
$54 to $60 trillion in the first decade. That's what his study says. Okay? I contend that's a misconception. And I'll tell you why. Let's just look at this for a second. Between $54.6 and $60.7 trillion sounds terrible. That comes out to between $5.46 trillion and $6.07 trillion per year. And we only, in quotes, spent $3.65 trillion last year. Looks like it's going to be a whole lot more expensive, right? So why is the amount in the Mercatus study so high? Let's look at that. The first thing is that Dr. Blehaus assumes an increase in total health care spending of about 6% per year. And at 6%, spending doubles approximately every 12 years. What number did I ask you to remember from the medical inflation? 6%. 6%, right? So that's a perfectly reasonable thing for him to do. is assume that spending is going to continue to increase at 6% a year. And at 6% a year, in about 12 years, everything costs twice as much. The second thing is that the decade that Dr. Blehaus analyzes starts in 2022. And the reason he did that was because he was looking at the Bernie bill, and it wouldn't kick in fully until 2022. So again, another perfectly reasonable thing for him to do. But again, at 6% a year compounded, that means we increase spending 26% before you even start. That makes sense? Okay? So that's what's pushing his numbers up so high. The combination of a 6% increase every year and starting 4 years from 2018 when he did the study. So, next statement. If we stick with the system we have, we would spend much less than we would. Let's assume for a minute that Dr. Blehaus is correct. If we stick with the system we have, we would spend much less. True? False? Myth? Misconception? Okay, so, being an engineer and a numbers nerd, I say, well, let's look at what we've got. I don't know if you can you see the numbers? So way over there on the left is the $3.65 trillion that we spent last year. The bar on the far left. And I've got it going up 6% every year. And so what do we have out here in 2031? $7.79 trillion that we would spend if we keep doing what we're doing now and we keep spending 6% more every year. And if you take, starting in 2022, where Dr. Blehaus started, go through 21 and add all those numbers up, here's what you get. So the bar on the left is the Mercatus Study low estimate. That's the 54 trillion that he said it could be as low as. The bar in the middle is the high estimate. That's the 60-some trillion that he said could be the high limit. And the bar on the right is what we spend with the current system. Again, $60 trillion. So in fact, the increase in spending is not coming from going to Medicare for all. It's coming from what? That 6% increase in spending every year. So the real key here is that the spending increase that they're projecting, that $32 trillion that all those congressmen were talking about, is not coming from switching to Medicare for all. It's coming from that assumption that spending will simply keep increasing at 6% per year. Statement. Other studies show much greater savings than the Mercatus study. True? Myth? Misconception? I mentioned before that the Mercatus is the highest number I've seen out of all the studies that have been done. So again, I'm going to play another little video here.
Your study shows that Senator Sanders' Medicare for All Act can provide universal coverage of every resident in the United States as the system as a whole absorbs a 12% increase in demand for health services. More people getting coverage are going to use more care. But it still realizes a 19.2% in potential cost savings overall. That and the cost of prescription drugs under your approach would be lowered by 40%.
This, I have to be honest, was a study commissioned by the Sanders Institute, which is not Bernie, but it's his wife. Okay, so, different direction. But it was done by these economists, you see their names there, at the University of Massachusetts, Amherst. They didn't just go out and make up a bunch of numbers. They actually went to these people, and there's a big group of people at Amherst that do medical economics. That's one of their primary things there. So in this case, they're saying a savings of 19.2% versus our current system. Is that number right? I don't know. My main point is that going to Medicare for all would not cost substantially more than continuing to do what we're doing. So if you have a choice of continuing to do what we're doing, where you've got lousy insurance and high deductibles and narrow networks and all that kind of stuff, or you can go to Medicare for all, where pretty much everything's covered, you go to any doctor you want, which one's better? They did some financing assumptions. I'm just putting this out there for information. They're talking about businesses, healthcare premiums cut by 8%. So they're saying that the businesses would continue to pay, but they pay 8% less, and they wouldn't have all the administrative work of going out and getting insurance plans for their employees, that sort of stuff. They also projected a 3.75% sales tax on non-necessities, net worth tax of 0.38%, and taxing long-term capital gains as ordinary income. That's something where the people who have lots of investments hate the idea of bringing up the capital gains tax. But the fact is that if you have capital gains, which is money that you get because your investment's value went up, you're buying in the stock market, you buy it here, you sell it here, you pay capital gains on the difference. And for people with pretty high income, the capital gains tax is way, way, way lower than the standard income tax. So there's a preference that our country has given to people who are investing money over people who are working and getting a paycheck. Okay, that's the way it is. So anyway, nobody knows how this would really be financed. That has not been laid out. It's not laid out in either bill. The other thing you should recognize is that typically the federal government doesn't collect specific taxes for specific things. Okay, there's no tax that you pay for the Defense Department, right? Comes out of general revenues. There's no tax that you pay for the EPA. Comes out of general revenue. There are a couple. Medicare, when Medicare taxes come out of your check, they go into the Medicare trust fund, same thing. Let's say I'm a business and I'm paying $10,000 a month for my employees' health care insurance. Okay? That's $10,000 comes out of my bank account and goes to the insurance company. So what they're saying is, I would now, I'd stop doing that. That $10,000 goes away. I would now pay $9,200 to the government in taxes. They just projected, because that's been a question everybody's asking, how would you go about paying for this? So these were just some suggestions that they threw out, and they said, if you do these things, and there's some other things in the study, it will raise enough money to pay for this. Well, bear in mind that the government is already paying for about half of that. Okay? You've got Medicare, where the government's paying, I've got the numbers here somewhere, but around $600 billion a year. And you've got Medicaid, which is in the, between the states and the federal government's in the $400 to $500 billion range. So if you look at it, the federal government's already paying about half of that 3.65. So in order to pay for the other half, you'd have to come up with about 1.8 trillion. So if you have a policy with your employer, most employers, you might be lucky to have one that pays 100%, but most of them don't. They typically pay about 2/3. The employee typically pays about 1/3. So that money is going out of the company's pocket and out of the employee's pocket right now. And so if you take that 3.65 billion, you look at how much is being paid by private entities, about half. How much is being paid by government at different levels? It's about half. Okay. So it's not like the government isn't paying anything. We've got to somehow or other raise $3.65 trillion in taxes. And that's really the weak part of all these studies and the two bills is there's nothing in there to raise taxes yet. Okay, next statement. There's no way to hold down the rising cost of health care under Medicare for all. True? Okay, I'm calling that a myth. Medicare can hold down medical inflation by controlling reimbursement amounts. How's it work now? The way Medicare works is it says, Mr. or Ms. Provider, I will pay you X number of dollars for this thing that you do. Okay? You can take it or you can leave it. So Medicare could say, let's say we went to Medicare for all next year, the year after they could say, we're not raising our reimbursement rates. Even though there's 1.5%, 2% overall inflation, we're not going to raise them. We're going to try to bring that percentage down. And so you providers have to become 1.5% or 2% more efficient in order to get the same profits off of what you're doing. Okay? So Medicare, remember I said there's very little in the current system that holds prices down? Well, Medicare is one thing that does hold prices down to an extent. And if we went to Medicare for all, absolutely Medicare could control what the reimbursement rates are and how fast they let them rise. I would assume at some point we get to some sort of equilibrium and say, okay, we think this is fair now, so we'll increase reimbursements by whatever the inflation rate is each year. That way the providers are kept whole. If inflation goes up 2%, their money's worth 2% less, so we'll give them 2% more to offset it. That's the way most things work. So there's no question that Medicare could hold that down. So now what happens to Dr. Blahouse's study if we assume a 2% increase every year instead of a 6% increase? All of a sudden, Medicare for all is much, much, much less expensive than if we keep doing what we're doing now and allow it to go up at 6% every year. Well, strangely enough, and again, you hear a lot of wrong information about this, but the insurance company profits are not a very big percentage of what we're spending. They are required under the Obamacare law to pay out 80 cents of every dollar for actual health care. Prior to the Obamacare law, they didn't have to pay out anything. They could have kept all your money and never paid a cent under the law. Obviously, under your contract, they would still have to pay that. So Medicare for All statement. Medicare for All would see a large increase in the use of medical services, so it has to cost more. So there's a bunch of people that don't go to the doctor right now, right? I heard a story about a lady, she had a hip was just completely worn out and needed a hip replacement. She was 62. She couldn't afford to do it. She turned 65, went on Medicare, and there was a whole bunch of stuff because she had gotten to where she didn't walk straight because of the pain and all that sort of stuff. But clearly, under Medicare for all of a sudden there's going to be people getting services that they either put off or couldn't afford to get, right? So clearly there's going to be an increase in the use of medical services. So it has to cost more. True? Myth? Misconception? Okay, I label this a misconception. It's true that usage was increased. There's no question about that. You remember, those of you who could hear that one video, he said a 12.5% increase in usage from that UMass study. So they said, yes, we'll be spending 12.5% more on people getting health care who weren't getting it. But there are savings that would offset that increase. So you have, that's why I called it a misconception. You have to take into account both. You have to take into account how much more we're going to have to spend because there are more people going there, but you also have to count how much are we going to save by doing this. So how are costs reduced under a Medicare for All system? We can see how there'd be more spending for people. That's pretty straightforward, right? Number one is elimination of most administrative expenses for providers. So those doctors that tell you they spend 35% of their practice income on administration, that's going to get cut way, way back because they don't have to mess with the insurance companies. And I know at one of these things we had a bunch of nurses say they spend half their time trying to deal with the insurance company. The doctor says this patient needs such and such, and they go to the insurance company, and the insurance company says, we don't want to pay for that. Then what do? Well, you go back to the insurance company and say, wait a second, this patient really needs this. Well, we still don't want to pay for it. So they go back and forth. And there's a lot of time and money and so on that goes into all this stuff. Your coverage under a private insurance company is governed by the contract that you sign with that company. So let's say I'm a company and I've got employees, I'll go out and buy something. It will say specifically in the contract that I sign with them what they're willing to pay for. So there's a whole list of benefits in that contract that says this is what they cover, this is what they don't cover. Under the ACA, there's a bunch of things they have to cover, and of course they can no longer do, kick somebody out for pre-existing conditions. Your kid can stay on your policy until they're 26. So there's some government things, but then your company, the company you're working for, should be out there negotiating to get the best possible deal for you. So anyway, if you don't have 104 revenue streams, you only have one place you got to go to get your money, you can see where that would drastically reduce administrative expenses, right? And then we already talked about Medicare sets reimbursement rates going forward. So that's potentially a very large savings under that 6% increase that we see all the time. Prevention programs for all. Right now, it doesn't really make a lot of sense for a private insurance company to really concentrate on prevention for you. Why? Because you probably won't be with them in a couple of years. Virtually every employer changes who they're dealing with every few years. At least that was my experience when I was working in business. So there's really not a good, strong incentive for the insurance company, the private insurance companies, to worry about prevention. It's not somebody else's problem. But under Medicare, it really makes sense to do prevention because it's much less expensive to prevent disease than it is to treat it. So there'd be a big incentive for Medicare to have prevention programs for everybody. Reduce drug costs. We already talked about that. 10% of our spend is pharmaceuticals. So 10% of 3.65 trillion is $365 billion a year. And if we cut that in half so we were getting the same prices as everybody else, that's almost over $180 billion that we would save every year just from negotiating drug prices. Do you know that there's a federal law that says that Medicare cannot negotiate drug prices? That was passed as part of the Part D. The government can't negotiate drug prices. The VA, strangely enough, can, and they pay about half of what the rest of us pay for the same drugs, just like everybody else in the world. So there's a big amount of money there. Elimination of unnecessary services. And what I'm mainly thinking of here is somebody goes to one doctor and gets an opinion about something that should be done. They go to another doctor, maybe get the same thing done. If you've kind of got it all controlled by one entity, that would go away. Increased efficiency, again, not trying to deal with 104 different insurance plans. And I think there would be a reduction in fraud because, again, everything would be going through Medicare, so it would be very difficult for somebody to charge a private insurance company and then turn around and charge Medicare for the same thing. So, next statement. This one's a little more controversial. Medicare for all is socialized medicine. True? False? Misconception? We seem to be hesitant here. So, that's a myth. Socialized medicine is generally defined as a system where the government controls all of the health care. So the United Kingdom, our U.S. Veterans Administration is, in my opinion, socialized medicine. In the Veterans Administration, the VA owns the hospitals, they own the clinics, they own the equipment, all the doctors are employees of the VA, the nurses and so on, they're all employees of the VA. So you could certainly make the case that the VA is socialized medicine. But Medicare for all is not, because services under Medicare are delivered by private entities, not controlled by the government. And the only thing that the government does is pay the bills. And your doctor decides what services you receive, not the government. So when you hear people say it's socialized medicine, or you hear them say it's government-run medicine, it's not. It's government-paid medicine. But the actual delivery of care is by private entities. Statement, Medicare for all has very low public support. True? Myth? Misconception? I'm going to call it misconception. You can call it a myth if you want. Public support for NEMA is growing. 70% approved of it in the latest Reuters, including a majority of Republicans. And that's way up over a couple years ago. So Medicare for all really is quite popular. It's unlikely to be implemented at the current time with the current administration, right? In order for it to happen, the politicians are going to have to get more pressure from their constituents than from the lobbyists. Okay? What most studies show is it takes about 80% support to overcome really strong lobbying. You know what the number one lobbying industry in the United States is? Pharmaceuticals. Imagine that. $250 million a year spent on lobbying by the pharmaceutical industry. Statement, we can achieve the same results as M4A by tweaking Obamacare. This is something that some people are saying, right? True? So I'd call it a misconception. We could cover everybody under Obamacare, but it would require massive federal government subsidies. Way beyond what we have now, because again, somebody's going to have to make up that 3.6, whatever we're short of that 3.65 trillion. It would do little or nothing to reduce total spending and spending growth. There's nothing in Obamacare that holds prices down, even though the name of the act is the Affordable Care Act. Okay, that's the one place you'd have to say that the ACA has been a total failure, is in controlling costs. Okay, couple more things here. Providers would receive about 40% less under Medicare for all. So we're talking about doctors and clinics and other practitioners. True? False? Myth? Misconception? Okay, I'm going to call it a misconception. You could call it a myth too. So here's the thing. Medicare does pay, on average, about 40% less than private insurance. But that 40% reduction would only apply to a provider who's only taking private insurance. Right? For that whole 40% loss to happen, That would have to be a provider who only takes private insurance. So providers would receive slightly more for patients who are currently on Medicaid, because Medicaid pays less than Medicare. They'd receive exactly the same amount for patients who are on Medicare if the reimbursement rates didn't change. The providers would receive Medicare reimbursement rates for all patients currently receiving charity care. And Mercy talks about, and other hospitals, doctors, they do some charity care. Well, they would get paid for all those going forward. And they would have no bad debt. Medicare for All would completely eliminate their bad debt, right? The government is going to pay for everybody. There's not going to be any bad debt. There's not going to be that person that shows up at the emergency room and they stabilize them and push them back out, and that person has no way in the world of paying that emergency room bill. So, statement, rural hospitals would struggle under M for All, with Medicare for All, and many would go under. True? Myth? Misconception? I'm calling it a myth, but you could call it a misconception. So, many rural hospitals are already struggling under our current system, and hundreds have already shut down. Those who have large numbers of Medicaid patients in charity cases might actually see a revenue increase. Okay, and I'll make this statement. If we're trying to set up a system where everybody can get the health care that they need, how much sense would it make to let hospitals go out of business? What the heck would we have achieved under Medicare for All? Because I guess the people that could afford to go to Albuquerque or Denver would be all right, but everybody else would be hurting. So there's been some talk of block grants for hospitals. What that means is, if you're on a hospital X, they go in and they look at what's your patient, how many patients do you have, what does it cost to treat those people, and they just give you a flat sum of money and say, here it is, you take care of everybody in your area. And then you would adjust that from time to time. So if the population is growing, you're getting more people every quarter, every half year, every year, whatever, you'd look at it and say, here's the new numbers, so this is how much money you need, and we'll give you that much money. And then it's up to you running the hospital to make sure that you get everything done within that amount of money. And that should make all the nonprofit, including rural hospitals, whole. Again, that's an idea that's been thrown out. And so, they would go through and do this for each hospital that fit into this. The for-profits, they wouldn't do that, probably. For-profit hospitals are making a ton of money right now. In Denver, all along the Front Range there, that's a great thing to be, is a for-profit hospital, because they're making a ton of money. So it would be more the rural hospitals where it's tough to operate when you don't have a large population of patients. So, again, the whole purpose of Medicare for All is to make sure everybody can get their health care. So that's what Medicare would be focused on. They wouldn't be focused on, like the insurance companies are now, on making the most money they can possibly make. Okay, statement. Doctors will stop practicing medicine under M4A because their income will drop. True? Myth? Misconception? If doctors are spending 35% of their practice income on administration, and most of that goes away, then even if they're getting lower reimbursement rates, it may offset much of it. The other thing is, how much of our healthcare spending do you think goes to doctors? Most people that I ask that without having seen the slide, I'll say, 25, 50%. It's only 8%. So since that's a relatively small percentage, we obviously can take care of the doctors, right? We can make sure that they don't stop practicing because their income dropped some huge amount. And it's not going to drop a huge amount. Okay, statement. This is for Karen. Government is inherently inefficient, and M4A, Medicare for All, will continue that. True? I'm calling it. The current Medicare system spends about 2% on administration and 98% on actually paying for health care. Private insurance companies spend about 20% on administration and profit, and only about 80% on actually paying for health care. So which of those is more efficient? Okay. But it's clear that there are, and I'm generally in favor of free enterprise, for most things. I cannot imagine the government building a car and that's the only car you can buy. But I think there are some things that the government does better than private industry. And taking care of people's health care, I think, is one of those things. Because the current system is not built to deliver health care to you. It's built to deliver profits to the pharmaceutical companies and the health insurance companies and the for-profit hospital chains. I mean, you think about it, what if you had private military? Private fire department. You know, what if when you called in and said, my house is on fire, they'd say, well, who's your fire department?
The police.
Police, same thing. So there clearly are some things that the government does more efficiently than private enterprise. Okay, next statement. There will be large tax increases to pay for Medicare for all. True? Myth? Misconception? What I would say is that statement's true. If the government's going to have to spend another $1.8 trillion every year, there's got to be large tax increases. But that doesn't consider the out-of-pocket savings under Medicare for all. So would you rather pay $500 a month to an insurance company to get a high deductible, narrow network, co-pays, double the price of pharmaceuticals? Or would you rather pay $500 to the government and increase taxes and get Medicare for all that covers everything, no narrow networks, no deductibles, no co-pays, nobody going bankrupt? Do you know that there is no such thing as medical bankruptcy in other countries? Doesn't exist. And most private insurance companies, after you have the deductible, you're still paying co-insurance. Most of them, once you meet your $5,000 deductible, they pay 80%. Guess who pays the other 20%? You do. So, again, all of that goes away under Medicare for all, that whole craziness. Okay, next statement. We can't be sure that Medicare for all will actually work. True? Myth? Misconception? I'm calling it a myth. Medicare for all would be very similar to the Canadian system, which has been working well for decades. It's about as close to a sure thing as you can get. Okay? There's no guarantees in life, right? I mean, nothing is absolutely guaranteed. I think Medicare for all makes the most sense as compared to those other systems. So we did a project, the company I was working for, we did a project in England, and one of our guys got sick. He went to the health clinic, they checked him out, said, you got this, they gave him some medications, they charged him nothing. Partly because they're not set up to charge anybody for anything. So it would be more trouble for him to bill him than it would be to just give him what he needed. And you find the same kind of thing around the world. I mean, it's different in every country. What Bernie Sanders has said is he wants to cover everybody living in this country, legal or illegal. Other people say, I don't want to do that. I don't want my money going to pay for somebody's medical care that's illegal. What I would say is, I don't want doctors and nurses to become ICE agents. I don't want them trying to figure out whether somebody's legal or not. I just want them to fix that person. Okay? And most of the people that are here undocumented are working, so they would be paying the taxes. So it's not like they'd be getting something for free, right?
Well, we also have to fix the immigration.
Statement, implementing Medicare for all will be a huge disruption in healthcare. True? So I think it's a myth. Implementing Medicare for all would be much less disruptive than implementing the other systems. You can imagine if we tried to go to a totally government-run system where all the doctors and everybody has to become an employee of the government, the government has to buy up all the hospitals and the clinics, I can't even imagine the disruption. So the first thing I would say is the Medicare system already exists. Okay, not like we'd be starting from scratch. Medicare already enrolls 10,000 new people every day. So they are used to handling large volumes of people. Their computer systems are perfectly capable of handling large volumes of people. Almost all providers already file and receive payment from Medicare. So you've got a system that's already in place. What you're going to do is expand the benefits and get everybody into it. Okay, is that disruption? Yes. Is it a major disruption? In my opinion, no. And it's certainly the least disruption of any of the systems that we've talked about. Medicare for all will result in long wait times to receive care. According to the Commonwealth Fund, we already have longer wait times than 9 out of 11 other single-payer countries. Okay? We have wait times. It's like you said, you already have to make an appointment. If I want to make an appointment to see my cardiologist, I got to go about 4 months out. You wouldn't have to do that in Denver. Okay, again, we've got less providers here population-wise, but yes, long times. What I think is wrong with what your friend said is it isn't going to go from a month and a half to 6 months, because we're only going to add about 8% to the population of people going to the doctor. So the doctor workload would go up by 8%, which of course means more revenue for them. That's another thing that would generate more revenue. So the reason I even put this in here is because one of the arguments against Medicare for All is we're going to get these long wait times. And they point to, other countries where they have longer wait times. But everything is prioritized. Okay, I had a friend in England, worked with her at NASA years and years ago. She met a guy, moved over there. She got lung cancer. She was in for treatment the next day. And they take care of the patients that have the biggest problems first, the ones that need to be treated right now. So the whole wait time thing, I think, is just a red herring. In Durango, my wait time to see my cardiologist is 4 months. In Houston, it was a week and a half. And that's going to be true in rural areas. So yes, there are wait times, but Medicare for All is not going to cause substantially longer wait times. And it will always be prioritized for the people who need the treatment right now. Okay, let's keep going. Medicare for All will result in people losing their private health insurance. All right, I'm calling it a misconception. By phrasing the question as losing something, it makes people uneasy. So if I say to you, hey, Medicare for All will cover everything, you won't have any out-of-pocket expenses, but you're going to lose your private insurance. What do you think? Wait, I don't want to lose something. But when you phrase the question that way, or you phrase the question, you do a survey and you phrase the question and say, do you support Medicare for All if it means you lose your private insurance? And, a lot of people go, oh, no, because they don't understand it. So there's no reason to have private insurance with Medicare for All. So you're not really losing anything. Why would you want to pay extra for something that doesn't give you anything extra? Okay, let's keep going. There's still quite a number of issues to be dealt with in implementing Medicare for All. True? Okay, this one's true. There are still quite a few issues to be dealt with, and it's the stuff we talk. First one is displacement of jobs in private health industry. Okay, number 2 is reimbursement rates for providers. Are we going to pay them Medicare rates? Are we going to pay them a little more? Are we going to pay them a little less? Are we going to pay everybody the same? Are we going to pay a little bit more to rural hospitals than we pay to urban hospitals? Or are we going to shift some of the money from specialists to primary care physicians? That's something I'd like to see. There's expected strong resistance from companies making big profits from the current system. Well, of course. Leading pharmaceutical, insurance, and hospital lobbyists have formed the named Partnership for America's Healthcare Future, an ad hoc alliance of private health interests to curb support for expanding Medicare. Why? Because they're making a lot of money right now and they don't want that to go away, right? So that's still an issue we have to do. And lack of understanding of National Improved Medicare for All among the public. This whole thing we talked about, private insurance is no longer needed. Okay? These are still issues we have to solve before this is going to happen. So what can you do? We're getting near the end here. The first thing is become informed. Tell your friends and acquaintances what's really going on, because people listen to people that they trust. Contact your elected representatives. We said that your representatives are going to have to get more pressure from their constituents than they're getting from the lobbyists. So you can do that. And vote for candidates who support real Medicare for All. So let me back up here. This Partnership for America's Healthcare Future, until about a week ago, the AMA was part of that. The American Medical Association has pulled out of that. They still don't support Medicare for All, but they at least pulled out of this organization that's trying to kill it. So there is progress, and this business of 70% supporting Medicare for All, that's only been for a couple years, okay? But things have changed dramatically in the last couple of years, and I think it's because the price is getting so high that people are just getting to the point where they can't afford it. So I think we're making progress, and if I didn't think that we could help make progress by doing this sort of education thing, I wouldn't be here doing it. So there's a guy in Pennsylvania who runs a company that has been advocating for universal health care. He's got a movie called Fix It, that if you haven't seen it, you can get online and watch it for free. But the other thing he did is they produced a short 8-minute video about myths about the Canadian healthcare system. And so they talk about what's going on in Canada, and they interview people and so on, from Canada. So right now, Medicare does not cover long-term nursing care. Okay, that's a big hole in Medicare. So the Medicare for All under both bills covers long-term nursing care. And the goal is not to make a bunch of money for anybody, it's to make sure everybody gets the health care that they need. So the bills have been constructed in such a way, the system is set up to make sure that you get the health care that you need, regardless of who you are, regardless of how old you are, how young you are, how much money you have or you don't have. It's universal health care. California has actually passed, the California legislature has twice passed a single-payer bill for California, and it was vetoed twice by the governor. There's been a bill passed in the New York, half of the New York legislature. I think it passed in the House and not in the Senate yet, but they're working on getting the Senate to go. There is a bill that was just passed in Colorado which directs the state to look at how we could get to universal health care. So there are efforts going on at various states, and Governor Polis during the campaign had talked about what he wanted to do was to get together with some of the other western states and come up with something that would cover 6, 7, 8 states until we get to the national level. There's no question that it's more cost effective and efficient at a national level. So the way this works in Canada is the Canadian government sits down with the pharmaceutical manufacturers and says, we're going to negotiate a price for your product, okay? And everything that you sell has to be at that price. We are the United States of America, we're going to negotiate prices. You don't want to negotiate with us? Okay, we're not going to pay for your medication. Okay? So yes, there would be a good bit of control there. So the price of insulin would come back down, the price of EpiPens would come back down. And if you think about it, suppose you got a drug you sell for $20, it costs you $10. If you double your price, you don't double your profit, you triple your profit, because now you're making $15 every time you sell one of those instead of $5. So there, I mean, just from a pure money point of view, for a lot of things, it makes sense to push the price up as far as you can push it. And that's what happened with the EpiPens. And that's what's happening right now with insulin prices. There is absolutely no reason for insulin prices to be where they are, except it's maximizing profits for the 3 companies that make insulin. So what I think all the economists would tell you is we are by far the largest economy in the world. And so when we sit down and say we want to negotiate, we are going to negotiate with the pharmaceutical companies that we would expect to be able to get at least as good a prices as any other developed country. The pharmaceutical companies only provide 20% of the R&D funds for the average drug. Most of the basic research and so on is done by the government or by, the American Cancer Society or so on. So yes, it's possible that if they had to cut their prices to us in half, they'd have to raise them a little bit for some of the other countries. They wouldn't be able to negotiate quite as good a deal. But why should we be paying twice as much as other countries? The fact is that we could easily cut our average drug prices in half. No question. Again, the VA did it, and they're relatively small. They got a 46% decrease. Well, but I mean, compared to other countries, and yet they were able to reduce prices 46% from what the rest of us pay. So if the pharmaceutical companies are spending $250 million every year on lobbying, it's not actually a partisan issue. Many, many Democrats take money from the drug companies. So, at what point do they decide, I'm going to do the right thing, what I would consider to be the right thing, stop taking money from those people and vote for Medicare for all? I think we're at the end of our time here and they're going to kick us out. Yeah.